The next talk is ASSIST, validation of a novel hybrid clinician-patient remote outcome measure for diagnosis of surgical site infection by Drs. Lathan from the Hull UK team.
Thank you very much for this opportunity to present the ASSIST study, validation of a remote outcome measure for diagnosis of surgical site infection. I'd also like to thank Professor Chetta, our supervisor, who's made the journey out from the UK with us. So the gold standard to diagnose surgical site infection is using the CDC criteria in face-to-face assessment at 30 days post-operative. The majority of infections do not become apparent until after patients are discharged, however. Following each of these patients face-to-face at 30 days is impractical, and remote assessment could be a possible solution to seeing these patients within the time frame. However, current available methods risk missing infections. A combination of remote modalities may improve the overall diagnostic accuracy, but has not been investigated until now. So the ASSIST measure uses a modified version of the Bluebell Wound Healing Questionnaire, which is a 19-item patient-reported questionnaire validated in general surgery. We hypothesized that 3 of these elements, swelling, pain, temperature, could potentially risk ambiguity, as they could be scored in the absence of infection but presence of other conditions by patients. A 4th item, the use of dressings, was standard practice, so it would be redundant within the measure. These 4 items were removed from the questionnaire. 6 elements pertain to visual wound elements. In the ASSIST measure, these are reviewed by a clinician on patient-submitted wound images. And the remaining 9 items are reported by the patient. This is a prospective cohort paired validation study nested within a randomized controlled trial that recruited patients undergoing procedures for high risk of surgical site infection. And we aim to evaluate the acceptability, reliability, and validity for the diagnosis of surgical site infection. So acceptability was assessed through response rates to the questionnaire, and in those that are returned, the missing items within those questionnaires. We looked at reliability through across 3 independent observers for the inter-rater intra-class correlation coefficient, and across the same observer on 2 separate occasions for the intra-rater intra-class correlation coefficient. Cross-tabulation of in-person versus remote assessment provided the criterion of validity, and plotting of the receiver-operator characteristic curve and calculation of area under the curve for the discriminatory ability to identify infections. So we looked at and recruited patients preoperatively and followed them up after discharge until day 30. At this point, they received a face-to-face assessment by a clinician, providing the reference standard, and additionally, the 3 independent observers who were blinded to each other's outcomes and the reference standard. This did occur at day 30 unless patients identified a wound-related problem early, in which case the review was done at that time. A subset of patients underwent a further review remotely, and that was deemed for those that had stable disease, defined by if they didn't have a change in admission status or re-intervention in between those 2 time periods. So we had a total of 98 participants, 5 of which died perioperatively, 2 had their procedures cancelled, and 2 further withdrew, and there were 10 non-responders. 14 participants were diagnosed with surgical site infection, giving an infection rate of 17.7%. With regards to our demographics, we had a standard vascular population for our cohort, predominantly male, elderly, and significant comorbidities. So with the 10 non-responders, gives a non-response rate of 11.2%. However, of those that did respond, there were no missing items in any of the questionnaires, indicating good acceptability for the measure. Across the 3 independent observers, the ICC was 0.913, and across the same observer across the stable disease, the intra-rater ICC was 0.992, with a greater than 9.9, indicating excellent reliability for the measure. With regards to the threshold score to diagnose surgical site infection, the cutoff indicated that a score of 5 would give optimal sensitivity and specificity trade-off, which also provides excellent positive and negative predictive values of 92.9% and 98.5%. Moving on to the ROC curve analysis, you can see the graph approaches the top left-hand corner of the curve, which indicates excellent discriminatory capacity for surgical site infection with the AUC of 0.99. And this excellent accuracy is maintained across observers 2 and observer 3. So where does this fit within the current literature? So we undertook a meta-analysis a couple of years back now, looking at telemedicine for the detection of surgical site infection. This had included 17 studies with over 11,000 observations, with a young cohort of 47.1 years, which we also found there were 3 independent remote modalities utilised across these studies: of photograph, telephone, and questionnaire. And summary sensitivity and specificity was 87.8% and 96.8%. Comparing this to the SSIS study, as you can see, the SSIS achieves good accuracy in a much older cohort, obviously being vascular, which has not been shown previously. Looking at the Bluebell wound healing questionnaire, which the measure was based upon, the original questionnaire, 19 patient-reported items, whereas SSIS has much less patient burden with only 9 reported items, in addition to the 6 that are reported by the clinician. The Bluebell is unable to be utilised as a diagnostic measure, given its low sensitivity, which again was improved upon with the assist. There is some work, however, to improve the response rates, in particular to the exact delivery method of the measure, and integration with primary care services who can support particularly those elderly patients who struggle with this response. Further sample size is required to evaluate the scale structure. However, if implemented, this could be utilised in a remote-first approach to post-operative follow-up. Thank you very much.
Hi, I have 2 questions. The first one is, what do you think the clinical applicability is of a tool that only has, 89% response rate and has been studied in younger populations?
As in the stuff, not including our work, the other work? Or?
Yes.
Low response rate, as a particular challenge. So you're risking 10% of your patients not getting any response, so that's quite a high rate of infections that you could be missing.
And the second question is, do you have any data on protection from either readmission or reintervention using that tool?
As in which patients required reintervention and readmission?
On the potential for reducing readmission and reintervention by using that remote monitoring tool?
So at this stage, no, because we looked at the paired validation at day 30 or when there was a problem. One of the things we do want to look at, and think the great utility will come about, is serial reviews. There is some data looking at if you have the reviews at set time points, with the option for patients to initiate in between that, you get greater response rates, and you can potentially capture that early infections rather than waiting to that initial single one-off point. So maybe like weekly or fortnightly. We haven't looked at that yet. That's future.
Thank you. Appreciate you bringing this. And it's one of the things that we have been looking at as a way to detect that at home, especially with COVID. A lot of the telehealth emerged, in the U.S. But in the NHS, and I apologize for my ignorance on this, is there a global period as well? Like, is there a lump sum the NHS pays for each surgery? And would that include the readmission for infection and so on as well?
My understanding is very limited on this as well. There would be a lump sum, I imagine, for that surgery, but that wouldn't include the readmissions, as would be my understanding. And then, so it would be additional cost per readmission for infections. So being able to prevent them, it would save the NHS significantly.
Okay, so that's the reason I asked that is if it's a potential cost savings, like is there a way that you could take that to the NHS and say, hey, look at this population, we've reduced the readmissions and so on. In the U.S. with the 90-day global period and so on, a lot of this care is not going to be paid for. And so for us, it'd be how do we capture the cost of implementing an electronic system like that that's going to be, if physicians are reviewing those images, how would we implement that in the U.S.? Because that'd be sort of out of pocket to us costs. So just an interesting study, and I appreciate you bringing it. And, the role of AI may also take part in this in the future as well, scanning those images for us. So
Again, that was another direction we were going to go in.
Although, Joe, you could argue that a lot of our physician extenders right now do this anyway. Like, how many times do they say, oh, so-and-so called and here's a picture of their groin, right? So we're sort of doing it ourselves anyway. Yeah, right. Like, you can't do your camera roll anymore because it's kind of gross, right? We all have that. Anyway.
How'd you choose 30 days? I feel like most of my infections come back in the, say, 7 to 14 day time period. I'm always surprised when somebody comes in at 30 days and they're falling apart.
Yeah, part of it was practicality for the study, using that CDC criteria for the simple infections. And that's what we tried to have, that practicality, so if there was a problem early, the patients could get in touch and we could bring that forward to keep it pragmatic.
I don't have a question, but a comment. Clearly, I just wanted to say they teach PowerPoint better in England than they do in the United States.
Thank you.
Thank you.
Cheers.